no. Then we can approve those. I guess ask Hackney to approve them.
Approved.
And City to approve them.
Chairman.
Yeah.
Yes.
Apologies. It was just under questions from the public.
Yeah.
I'm not sure if the papers are online. I've just had a member of the public ask where the papers are, and I know we received the final pack late last night. That does make it rather difficult for the public to work up a question, inform Alex of the question to put it to the meeting.
No,
So,
I do appreciate that, Marianne, but you know the problem we're working with, which is that the decision-making officer board that meets till about 5:30 the evening before, so the papers are literally hot off the press. And if we get them earlier, they won't have any of the more recent data.
Yeah, well, may I just suggest that if members of the public are in the meeting and they wish to ask questions throughout the meeting, that they're able to put something in the chat box and the questions answered that way.
The public link wouldn't let them into the chat box, I believe, but certainly at any point they can email Alex and he will convey it to us. I think, in this very rapidly changing situation, we have to try to go with the most recent information we can. And of course, we're all members of the public as well. So, we're not entirely unrepresented. But thank you for raising it. It is a problem. I agree. Right. So the first substantive paper we have is the vaccination program update. Siobhan. Siobhan? Are you frozen?
If Siobhan is frozen, I can come in. I was going to talk to this item.
Yeah.
Siobhan was going to introduce it, but I think we've lost her. Oh, she's here. Siobhan, we were just going to kick off the vaccination item.
I think she's frozen again.
She has frozen again. I will just start talking. Thanks everyone. Thanks for having us back again this month. So we've included in your pack the latest position on the vaccination programme. Essentially, this summarises an overview of the numbers and some of the key policy decisions around vaccinations recently, and then a little bit more detail on our community outreach vaccination work and also on the work with children. So to summarise across the first 3 slides, we're currently at 71% of our cohorts 1 to 9, that's everyone over 50 of our residents being fully vaccinated. So that's across City and Hackney. And across cohorts 1 to 12, which is everyone over 18, we're at 55% fully vaccinated. So there's still more work to do with those younger cohorts, which we know is a focus for us. We're continuing to push on the evergreen offer, which means that offer of a first and a second dose for everyone who is not yet fully vaccinated. And we're still pushing quite hard on that with younger people and with specific communities where we can see lower uptake rates. In terms of kind of recent policy decisions, it's fair to say that we've had a few, it's been a moving picture relative to what we expected and actually what has come out. So in terms of the booster programme, at the moment we have not been instructed to run a full booster programme, but we have been asked to run 3rd doses just for immunosuppressed people. So a small cohort of people will be offered a 3rd dose. And we are waiting to see what the JCVI's guidance is for a broader booster programme. And we're hoping to get an update on that next Tuesday. Similarly, for 12 to 15-year-olds, despite what we expected, they haven't recommended that we give a universal offer for 12 to 15-year-olds yet, but they have asked us to just deliver the jab to children who are clinically extremely vulnerable. we may still hear that we have to deliver a universal offer, and we have been told to continue to plan for a universal offer, although that hasn't been kind of nationally sanctioned yet. Again, we're expecting to hear further updates on that next week. So that's the kind of overview of the numbers and the kind of policy position. Going through the pack, we've then included a page which is on, I can't see page numbers, your page 11 in your pack, which is again an overview of our community outreach work. So this describes all of the different pieces of community outreach and pop-up work across the borough. We've agreed to continue our community grant funding programme, which is where we can give grants to local voluntary and community organisations to support our outreach work. So they would specifically support running pop-ups with specific pieces of engagement, whilst we obviously would deliver the vaccinations in tandem with that. One of the things we're about to pilot is looking at a delivery of an outreach within an estate. So we're going to go into the Kingsmead and Clapton Park estates near Hackney Marshes and trial doing a vaccine pop-up in an estate. We'll take the learning from that, and if it works, that is a model that we could replicate across other parts of City and Hackney. We're also doing a bit of a wider review of our whole pop-up outreach offer to look at whether we could potentially extend it, i.e. deliver more or a kind of broader offer around pop-up with a kind of more local authority resources and vaccination resources supporting that. And in tandem with that, we've come up with a prioritisation framework so that we can better plan for where we target our community outreaches going forward to really make sure that we get the best impact from them and that they really do address the health inequalities that we're seeking to address. But hopefully we'll get some good learning from the estates pilot to take forward through the next few months. The next slide, which is page 12 in your pack, is what is the current work with children or with 12 to 15-year-olds. So as I said before, we have not yet been asked to give a universal offer to all 12 to 15-year-olds, but we have been asked to start vaccinating clinically extremely vulnerable 12 to 15-year-olds. In the borough, that's just under, well, it's about 15,000 people, or children, sorry, it looks like. Although there's a little bit more work just to validate those lists with all of our different services to ensure that is the right number. What we are going to do is we will be writing to those individuals, and we will be delivering vaccinations for those children, both in our LVSs and also going into special schools. And in the LVSs, we will find dedicated weekend times to invite children to, so we don't disrupt schools and so that we can create a more child-friendly environment at specific children's times.
Sorry,
likewise.
Nina, just you used initials there for something that
so sorry.
All the public will know what that means.
Thank you, Randall. I'm sorry. SEN is special educational needs. So it's those schools that support children with more complex complex learning or educational needs.
And LVS?
LVS, dear, we slip into it too much, don't we? Local Vaccination Service. So our local vaccination service are the two primary, we have two in the borough, and they're the two services in Bocking Street and at John Scott Health Centre that are being run by the PCNs to deliver the COVID vaccination.
Right. Thank you.
So those are the two settings where we will be delivering vaccinations to clinically extremely vulnerable children. As I said, we've also been asked to plan for potentially having to mobilise a wider vaccination programme for all children. So we're waiting to hear the update on that. I think that covers the final slide. Just gives them an overview, which we presented to you before, of where the different delivery models, an overview of where vaccination is being delivered across the borough. So where vaccination, both flu and COVID vaccinations are being delivered or will be delivered once we get the flu vaccine across the borough, across our GP practices, pharmacies, the local vaccination services, and hospital hubs and outreach models. So that's just to give you an overview picture of the different locations that we are using to deliver our total COVID and flu vaccination programme. Just to note on flu, we have been told to expect that this could be a difficult year for flu, given multiple years of, or over a year of lockdown. So we are also very much focusing on getting the flu jab out to as many people as early as possible. And as we said before, the eligibility for the flu jab will be a slightly different cohort than eligibility, although there's overlap, than eligibility for any COVID boosters if there is a booster programme. Likewise, people will become eligible for the flu jab a lot earlier than they would potentially become eligible for any COVID boosters if we were to go down the route of COVID boosters. So we are very much focusing on getting flu jabs, a flu programme running this month as quickly as possible. That's quite a whistle-stop tour, but I will stop there and open to questions.
Okay, any questions? If people could use the raise hand function. Yes, John, thank you.
Thanks, Randall. Nina, you just mentioned about the focus on the flu vaccine. I've heard a still report in the Health Service Journal earlier in the week saying there might be delays of the vaccine. So do you think you can achieve starting this month, or do you think it might slip into next month?
Yeah, good point, John. So there's lots of rumours around this. We haven't been given any official kind of numbers or timelines around receipt of the flu jab, though I think there will be potential supply issues. So I think we're just getting ready to go as quickly as we can once we get the supply. But you're right, that is a risk that we are alive to. Thank you.
Any other questions? Chris.
Thank you, Nina, for the comprehensive update. I think quite a few of us on this call volunteer at one of the local vaccine centres, try and do a shift, one shift a week, and they are painfully quiet at the moment in terms of people coming forward. I hope that the pilot. So it feels in the vaccination centres that the people who want to come to us or make an effort to come to us, or are being directed to book at the sites, that those numbers have really got very low, and that actually taking the vaccine to people, as the pilot on Kingsmead and Clapton Park estates, which I really welcome, looks like that might be the way forward. And I wonder if we're thinking that at some point actually we might pivot towards a model more like that, although I have heard that that evergreen offer at the two LVSs will continue certainly until Christmas, but there seems to be a lot of resource there sitting there not doing anything at the moment, or very much. That's what I'd say. Thanks.
I think that's a really good point, Chris, and I think your insight from the very front line is helpful, and it is also what Alex, as you know, who is the operational manager for the two vaccination services, is telling us. And I think we need to take. I think that's good reflection. I think we need to take a balance between keeping some capacity at the local vaccination services, because we've done, to continue to manage and deliver for walk-ins. But I think, targeting more capacity on the outreach is what we should be thinking about. And as I said, we're having this kind of broader conversation about, is there more scope? How can we broaden the scope of our outreach programme to really get those people who will probably never come forward to the vaccination service? That said, if we need to continue planning for a booster programme, the bulk of a large majority of the boosters will be done in the local vaccination services, because we know we've got a high number of people who are willing to get a COVID vaccination and were willing to come to the vaccination service for their first two COVID vaccinations, who will want to come back to them, who will be able to come back to them for a booster. So I think we just need to keep that in the, that's part of the reason for keeping them going. But I agree, we can target their resources onto outreach, and they have been using some of their resources to support outreach, but I think there's more we can do with that. Definitely. I'll take that back.
Yeah, I would just echo what Chris is saying. I think, we in Port Soken ward, which is the one part of the city that has lower uptake, we have two large estates that I'm sure that we would be very happy to help you operate pop-ups at. Antoinette?
Thank you. Similar point to Councillor Kennedy, really talking about the numbers lowing in the vaccination centres, but also I'd be keen to understand the footfall of the pharmacies that are taking part in this programme, because I know that when I volunteered at one of the pharmacies, people were coming in. This was where they had a post office, so people were coming in to try and use the post office, and we had to explain it was closed. So I wonder about using spaces where people naturally always go anyway, to raise more awareness, and sort of keen to understand if there has been any learning from the pop-ups aimed at young people, what's worked and what we can do differently to make this available for young people that are interested in becoming vaccinated, because I'm noticing they are still the cohort that hasn't had the highest number of vaccinations, but also when you look at the cases of people getting COVID, you're seeing it happening among a younger cohort. But I'm sure if that isn't quite right, Councillor Kennedy will politely correct me, because I know that he's full of this data and knowledge. Thank you.
Thanks, Antoinette. On your first point around the pharmacists, pharmacy numbers have dropped off as well as the LVSs, but I don't think quite to the same extent. And I think there's learning from that in terms of they are much more locally used resources that all people do go into for, as you say, post offices, but also just to pick up their general day-to-day items. So I think there's definitely learning from that in terms of really using our pharmacies as much more local delivery units. In terms of your second question around what has worked in the pop-ups, this is a piece of work that we're looking at the moment. What seems to come back is that going to people works. So the feedback, particularly from 18 to 25-year-olds, is come to us. Also, having some sort of a sustained pop-up, so not just a one-off, it's an afternoon and then you go, but having it over a number of days so people learn about it and can tell their friends about it, and you can pick up the activity around it. And then that outreach around the pop-up is absolutely key. So getting that kind of local community group to do that sustained outreach for a few days before and around the pop-up, and giving the time around the preparation of the pop-up to do that, is also what has worked. As I said, we'll get more learning from actually going to an estate as well and seeing whether that brings more benefits. What was your final point, Antoinette? Sorry. Covered pop-ups, pharmacists.
Pharmacists, I suppose it was just more about young people as well, because increasingly they are the cohort that now are catching COVID.
Yes.
Entering hospital with COVID, and just thinking about how we can use the pop-ups and going to where they are going to kind of encourage uptake and increase.
Yeah, so those insights I gave were specific to young people, and we are very much focusing on young people. And you're right, at the moment, our highest case rate for COVID is in the 20 to 24-year-old age group, although that might shift younger now that schools have gone back, which will be interesting to see. But yeah, that is very much the focus. I completely concur with that.
Thank you.
Okay, Marianne?
Thank you, Chairman. Just can I have a quick update? So I know we were hoping to organise a pop-up on the Mansell Street estate during their open weekend. Did that happen? Because I'm aware that, as Randall says, that area desperately needs to improve the vaccination take-up, especially with city workers coming back. And we've been quite protected, and people need to understand that they really need to get the jab now. So can you just give me an update? Did that happen? If it didn't happen, what pop-ups will we be sorting out and organising for the city residents? Thank you.
I'm honestly not sure, Marianne. I was on leave last week, but I can pick it up with Bev, who's managed our kind of outreach programme. And then in terms of pop-ups that we can be planning for the city, I think we, as I said, I think as part of the city will absolutely feature in our kind of planned pop-ups going forward. And I think the learning, as I said, we've got this so there's two things happening. We've got this prioritisation framework to kind of plan our pop-ups, which will absolutely feature the city. If the work from the estates pilot works, then we'll be rolling out more into more estates, and we can absolutely plan to go into. And then there are two within the city. Currently, there are two potential clinics on the east of the city, and in the clinic sites on the east of the city and in the south of the city that we are scoping as well for pop-ups. So I can give you a further update on where we get to with those, Marianne.
Okay, and
that's great. Thank you. Thank you.
And what I think will probably be the final question, John Geeve.
Hi, thanks for a very good update, Nina, as usual. On the school-age population, which we're expecting a decision possibly today, I think, or announcement today. Presumably we do most of those in school, would we? And I was just wondering about the older, the 16 to 25 population. Many of those are students. So are we offering vaccinations in colleges? I don't know if the colleges have opened again yet, but they're allowed to. Is that a possibility?
Good questions. So for the universal offer for 12 to 15-year-olds, yes, we would be looking to do an offer both through the local vaccination service and through schools. And I think we've kind of reached out to we'll be reaching out to local schools to try and coordinate it across those two, and hopefully making that a kind of offer of either. In terms of the current 16 to 17-year-olds, we aren't currently vaccinating in colleges, but I think that's a good point. And this is, as you can see in the numbers at the beginning, this is a population where we've still got quite low uptake. We're only on 19% for that cohort. So I think that's something we should take back and explore to see if that's the route to increasing uptake for that cohort, because what we're currently doing, we're still not yet seeing large numbers.
I chair the City of London Academy Hackney, which is right next door to the Homerton, and I'm confident that we would happily host you.
Okay. I'll come to you, Randall, then.
Siobhan, now that you're reconnected to us, did you want to add anything?
Thank you, Chair. So apologies for that earlier. Yeah, I mean, I guess just to add, there is a lot of focus across the whole of North East London around the younger cohorts, and there's a lot of planning going on with the organisation that does routine vaccination in schools, because obviously that's not something that's unusual. It does happen, and there are lots of activities trying to work out the scale and the scope of what that would look like in educational establishments. But the kind of lack of clarity around the announcement is kind of, it's a bit of a moving feast on a daily basis at the moment. But I think so it's quite hard to plan in a robust way around that. But those are all very helpful suggestions, and particularly Honour's ideas in the chat as well about other health and wellbeing settings might be something we should explore. I mean, we are looking to kind of commission our own outreach service, and apologies if Nina already said that, because I missed all the preamble. But so it may well be that as part of an ongoing approach with our own designated team, we will be able to do more targeted outreach more systematically than we have been in the past. So that's all I'd add.
Yeah, I would just note that, all of these 6 forums have had to organize testing, and it seems to me that the vaccination shouldn't be a significantly different organizational structure. So I don't think it would be a really large burden on them.
No, I agree. But I guess the other thing just to be mindful of as well is there's, the anti-vax sort of has stepped up a gear, really, I think, as we've moved into this younger cohort, and it's something that we need to also factor into our planning from a security and sort of safety point of view as well for some of the staff. Stephanie.
Thanks, Randall. I was just going to add a bit more to the point that Siobhan had said, just around recognising there are differences with the with approaches and feeling and emotions associated with the testing versus vaccination. And we know that there are some schools which have already said that locally that they don't want to have vaccinations on the site because of concerns around anti-vax and concerns around all those sorts of things. So I think it's a complex picture that we'll need working through as part of that. I don't know who the schools are. This was just something that was raised in the vaccination steering group yesterday, that not all educational kind of environments and estates will be kind of receptive to having vaccinations on, particularly I'm thinking here around the universal 12 to 15 offer, if and when that comes. Not necessarily, I'm not talking about those with in 12 to 15 who are clinically extremely vulnerable or in SEND schools, because actually the initial uptake we've had from SEND schools has been very, very positive.
Yeah, the universal 12 to 15 has a whole additional layer of parental choice and who gets to decide and other things that do make it more controversial. Right. Okay, I think we can go on to the next item then, which is the data intelligence. And Diana, are you here?
Yes, good morning, everyone.
Right.
I will give you just a quick update on what's happening with our cases and testing and hospitalizations. I hope you can see my screen, and it's the right one where there is a chart showing the number of cases.
So we've got leading indicators.
Oh, sorry. That's the wrong one. I'll try again. There you go. Should see the correct one now. So as you can see from this chart, this is the case rate for City and Hackney. And since July, where we had the highest peak, so around mid-July, the number of cases and consequently, as a consequence, the rate has been reducing. It's relatively stable right now. It has reduced further in the last 2 weeks. And where increases do happen, they tend to be quite small, like this, so around 3% for Hackney since the last week. So that's good news. Throughout this third wave, the highest incidence rate we saw was within this age group, 20 to 39, and the largest reduction that we've seen in the past week was within that age group as well. So that caused this large reduction in the case rate overall. However, that's not the case for other age groups, especially 60 plus. So when we look at the trend for that age group, since the beginning of August, it has been steady, even if small, but steady increase in the number of cases within the oldest age group, so the most vulnerable cohort, which can cause problems and higher hospital admissions potentially, especially if that population has not been vaccinated. We have already seen that, and I'm going to go on in the later visualizations to show you what's happening. When we look at a bit more granularly, so this is in 10-year age groups, and that's the difference since last week. So we're definitely seeing an increase in younger ages, so the number of cases increasing among the youngest. And like I said, also there tends to be week on an increase among the oldest age group. The distribution within Hackney and the City of London, so within Hackney wards, there's quite a bit of variation. So some of the wards seeing relatively low case rates, and that's the blue color, and 2 wards are seeing over 300 per 100,000 incidence rates, and that is, apologies, it tends to refresh itself, in Hackney Downs and Kings Park most recently. And it's good to hear that the colleagues within the NHS are going to start some work within that area, because it does tend to show worse outcomes than some other areas within Hackney. How we compare to other boroughs, so we are towards the lower range of the distribution. So here we are, City and Hackney. That's our case rate for the most recent week. But just relatively, the differences are not that large. So it is, our case rate overall is 220 per 100,000, and the highest, which is Ealing, is 299. So the differences are not huge. And in London overall, the picture is quite stable. So some local authorities, again, seeing an increase in case rates, but they tend to be small. Although when I looked last, I've noticed that compared with just a couple of weeks ago, more local authorities have now moved into that highest incidence rate bracket, so over 250 per 100 population. So even though the increases are small week on, they kind of accumulate, and more local authorities are now seeing relatively high incidence rates. In terms of testing, so again, the picture with testing was quite stable throughout August. In the most recent week, we've seen a decrease in the number of tests that has been taken locally, and we've also seen an uptick in the positivity rate. So that's the proportion of tests that come back positive. It might not be the trend, it might be just an odd week off, and we will know more when we continue observing this trend. But it logically does follow. So when you don't have enough testing within the population, you tend to pick up higher proportion of positive cases within that whole testing cohort. Vaccinations have been discussed already in quite great detail by Nina. And just to mention hospital beds occupancy, we have seen an overall reduction in the number of patients with COVID in hospitals. However, those that are most serious cases have remained stable or increased slightly. So while the overall number of patients with COVID in Homerton has decreased, that's not the case for the most serious cases. And recently, colleagues from the North East London NHS have conducted a piece of research when they looked at the cases within the ICU, so intensive care units, and they found that almost 90% of all the patients that were there with COVID haven't been fully vaccinated. So that's just again to reiterate the importance of vaccination and how it can prevent from serious complications from COVID. It is a general trend when we see an increase in cases, which follows by an increase in hospital admissions, we tend to also then see an increase in deaths. And since the beginning of August, we have seen several, so 4 or around 4 deaths every week, so with an exception of this week. But like I said, so it does tend to follow through. So increase in cases, increase in hospitalizations, and sadly, increase in deaths. And that's just, again, another good reason for people to get vaccinated and keep promoting that vaccination is available to them. We have done a little comparison between wave 2 and 3, and just wanted to illustrate what I said about how the waves of outcomes tend to follow. So for wave 2, we had a peak in January, and then hospitalizations just a week later, that's when the peak occurred, and deaths just a couple of weeks after the peak in hospitalizations. So we are going to keep updating this. So that, we've done it a few weeks back, so this is not the most up-to-date data. The most recent wave is in orange, so 2021, so that's the 3rd wave that we are seeing now. And we will keep following the trends of what's happening with our cases and with our hospitalizations and what the epi curves are looking like now in this 3rd wave. We are expecting to see an increase in the number of cases, as happened in Scotland when the schools went back, but it might not mean that we will see the same kind of impact we saw in terms of hospitalizations and deaths versus wave 2, so last December, January. And I think that was all I wanted to say, maybe with an exception that in UK overall, we are actually seeing, while in London, and in Hackney and City of London, the picture is relatively stable. in UK, we are seeing an increase in the number of cases, and deaths continue to increase. Hospitalizations are also on the rise. So it might be that in London, the picture will change kind of in line with the UK's picture in the coming weeks.
Right. Thank you. Catherine Pelly.
Apologies, it took me ages to unmute myself. For those of you who don't know me, I'm the chief nurse at the Hamilton, and I'm here for Tracy Fletcher, actually. This is really kind of interesting kind of data around the COVID impact on hospitals. Of course, there's a difference this time than we didn't experience in waves 1 and 2, is the rest of our activity. So we saw a significant drop off in other activity into the hospital in waves 1 and 2. We're not seeing that this time. So whilst the COVID numbers are relatively stable, although worrying, actually it's now added to by everything else as well. So the hospital is incredibly busy and ITU is very busy, which is a different kind of way of needing to manage that situation.
And Mark Ricketts.
Thanks, Randall, and thanks, Diana. Again, a really helpful, clear report. I just wondered what you'd say about testing rates, and particularly testing rates, what we know about them, a differential between different sort of neighbourhood areas. Do we have much in terms of how that's going? Obviously, to want to put that in the context of COVID diagnoses, whether testing is being maintained at previous rates or changing up, down, and how that cuts across different parts of City and Hackney.
Sorry, when I share screen, then the screen that you're on disappears. We do know that, so we follow that as well, and we can see that within the testing rate. It's the picture that we tend to see in the north, within these three wards, especially Cazenove and Springfield and Stamford Hill. The rates are the lowest compared to the rest of Hackney. City of London tends to have higher rates versus Hackney, but that does change, and within different demographics as well. So sometimes we notice a drop-off in certain communities, but that is communicated through to the working groups and they can act on it. But yes, so we do know that in general, the north of the borough tends to have lower testing rates, and sometimes it comes through also that we pick up less cases, but it's not always the case. Sometimes we do see that actually this is higher than anywhere else, despite the lower testing rates. It just shows high community transmission.
And am I right in thinking that overall in Hackney, that bottom, the right-hand corner one, that generally looks a little lighter blue? So is it generally going down across Hackney as well, apart from the city in that one there? Or because it's difficult to see the difference in shading
around here?
Well, just meant in general, yes, across Hackney, it looks like the colour is changing to a slightly lighter hue compared with the one directly on its right, I say.
Yeah,
so I just wonder whether it's generally going down as well, whether there's a shift.
So there is definitely a variation within Hackney, and most recent data shows that, again, that actually are filtered to the most recent week, and it hasn't changed that much. It just tends to present in this way. North lowest testing rates, and some of the wards stubbornly also lower than other places. But like I said, this intelligence does go to the testing working group, and they tend to target the comms to the areas where they see the lowest uptake, and that's concerning not just testing but also vaccination and other services.
Yeah, and thank you. When you refreshed it again, that different in colour went, so clearly the trend is. Thank you. I can see that now. Or there isn't a general trend down. It just as you said. So thanks for that.
Okay, Sandra.
Thank you. Good morning, everyone. Thank you, Chair. I just actually wanted to say that I can respond in a bit more, with a bit more information, not necessarily more detail, to Dr. Eggers' question from the information in the Outbreak Management Report, which is coming next.
Good. Actually, why don't we just go straight into that?
Thank you. So I wasn't going to give a summary because it's actually quite brief, and I'm hoping you'll all have read it, but I just wanted to point out a couple of things, one of which is, or the key thing is the change to the testing regime. And rather than having a lot of standing asymptomatic testing sites for people to go and have lateral flow tests done in a testing centre, generally this is the move from, or the direction that we've been given from Department for Health and Social Care. They're going to be standing down those sites and moving much more to a community collect, test yourself at home type model, where you can pick up these asymptomatic lateral flow test kits either from a PCR test site, from a pharmacy, and we have them also available in various other places, including community centres, estate halls, etc., so that people have easy access to them. And to speak to that specific point about where testing uptake is low, we're not just targeting communications, but also the testing outreach team is doing engagement in those areas and trying to make sure that we are preventing better opportunities, as well as encouraging people from those communities with low testing rates to be tested, which was the whole motivation for that move by DHSC, so that we can have not just more equitable testing, but also that we make sure that we're picking up infections in those communities that were under testing. And then I'll just present, if this works, a page from the presentation, which should show you a graph of testing over time. And so I'll just make that slightly bigger. So you can see the dark blue bars are the PCR tests, and this is starting in May 2020, actually up to the middle of August this year. So dark blue bars, PCR tests, obviously we had very little community testing in the beginning, and the light didn't have asymptomatic testing in the beginning, and the light blue bars are the lateral flow tests. And the orange line here is the positivity rate. So this accords with what Diana just showed you, that we've still got a relatively high positivity rate. So even though the rate of testing has come down both for lateral flow testing and PCR testing, the positivity rate has actually been going upwards again a bit, and this is across the whole of City and Hackney. But this is giving you an indication of testing rates which have tended to follow infection rates, although, as I said, in the last few weeks, the rates have come down, even though the positivity has remained high. So our targeted lateral asymptomatic testing campaigns, and then continuing to encourage people to test when symptomatic with a PCR test, as well as contacts now for people who are direct contacts of a positive case, or an asymptomatic or a symptomatic person who are fully vaccinated or under 18 and are no longer required to self-isolate unless they have subsequently a positive PCR test. So direct contacts and people who are symptomatic are all being encouraged to test with PCR tests, and that's the key change in the testing regime, which is what I wanted to point out from this presentation. And then the other thing was, which is not in the paper, is that we will be now including the Contain Outbreak Management Fund in our financial reports to this board. We're at the moment developing a framework that helps us make clearer decisions about where we're spending it. It wasn't quite as obvious as with the Test and Trace grant, but we will be doing that in the next week or so, and we have already obviously dispersed some of that money, but the rest will be subject to this framework for allocation, and we'll be reporting that to the board.
Good, thank you. Are there any questions? No, then we actually have finished a couple minutes early. So I guess we'll take the short break, and I'll see everyone back here a minute or two before 10 so we can start promptly at 10. Thank you.
Siobhan, have you sorted out your IT?
I think so. It's just, I think, you know, sometimes if you don't log off properly and then you go back in, you think it's going to work and then it just doesn't, and you have to restart the whole thing.
That's so annoying.
I know.
You froze in a very attractive posture.
Oh, that's good. There's a silver lining. Thank goodness for that.
It's when you freeze with your mouth open.
I know, it's horrible,
mid gesture.
isn't it?
It's just terrible.
It is. I know there's a lot of sort of like how to best maneuver yourself on the. It's interesting though, you know, because you really realize, I think, when you go back and have contact with people, how flat a medium this is. You know, like you get very used to it because you're doing it all the time. But when you go back and have an interaction with people, it's just like something else altogether.
It's the whole body thing as well.
Yeah,
isn't it?
yeah.
Because it makes me realise how much I rely on lots of other things as well as people's faces. Okay, I'm going to mute myself now, not
Same.
chat on.
So Alex, does it look like we're both quorate?
Let me just see. We are for the city. And yeah, we're quorate.
Great. So it's just turned 10, so I guess we probably better start. So welcome everyone. We have a couple items for approval today, so we're back in decision-making mode. Alex, could you give me the apologies?
The only apologies are from Councillor Chapman.
Okay. And declarations of interest, we have register of interest, and I guess we've noted that one person who should be on there isn't currently, so we'll pick that up. And questions from the public? I'm not aware of any. And then we have the minutes of the previous meeting. Does anyone have any questions about that? We also have the action log. Is there any questions about that? Then can the city approve the public minutes and also ratify the decisions we took at the last meeting, which we unfortunately were incorrect for? Yes, good. And can Hackney approve the minutes?
Approved.
Good. And we're both noting the action log. So we'll turn to item 5, which is the ICS update, and that's Siobhan.
Thank you, Chair. And apologies for the late circulation of these short slides, but I thought it was important that we revisit this this planning process as soon as possible, and with a brief update on the process that's in place now across the whole of North East London. I'm aware that a number of you are involved in a number of the forums that are the senior leadership forums that are working up the detail of the plan, but I thought it would be helpful just to kind of reiterate what the process is going to involve. The main objective at the moment is which has been to kind of create some coherence through the process, because it is a vast process, and we've broken the plan has been broken into 3 programme areas, which you can see on the first slide, which I think is actually a really helpful structure for us to think about the future, because there is an awful lot to consider, and it's broken into these 3 areas. One which is the kind of very technical side of the process, which is about the closing down of the CCG organisation and establishing the new organisation, and all the kind of associated technical issues that go along with that in the context of finance and the staff, etc. And that's a straightforward sort of set of requirements that we know we need to deliver by the particular date of end of March next year. Then there's a programme of work around how the system will be designed and what it will look like, and that's where some of these forums are very active at the moment in starting to think about the design principles of the ICS, how it will work with place-based partnerships, how it will work with provider collaboratives, what's the scheme of delegation, etc. And then there's a piece around strategy and service transformation, which again, both of those are longer term in the sense that they're not things that we will necessarily have finalised and concluded, but we will be well on the way in terms of establishing those by April next year. Then the second slide just details some of the forums at the moment that are leading some of this work, and some of those are led by Marie Gabriel, and I know some of our local authority leads and partners are involved in some of those settings. There's a sort of a chief executive led group as well that's meeting on a regular basis to consider some of the proposals in a bit more depth that are being developed by directors of strategy across the whole system, which we are obviously actively involved in as a City and Hackney partnership. And then there's going to be a more detailed sort of steering group that's being refreshed at the moment, and then other things will be developed on a thematic basis, and that's the way that areas of work are being considered by these forums. There's a planned event on the 6th of October, I believe, which I think a number of you will be invited to, and that will really sort of set out and agree the design principles for the ICS and what the priorities will be across the whole system. And I think once there's that kind of consensus, a lot of the activity will then flow from that perspective. The senior roles for the ICS are starting now to be advertised. So the Chief Executive Officer roles are being advertised nationally, and I think there's a kind of expectation that by November time, some of the more senior appointments across the system will flow as a result of that key appointment, obviously. And then there will be subsequent appointments of the medical director and the chief finance person as well. So you can see a sort of a flow of that timetable, really. And then the other key thing is just at the end of the document that I circulated is this readiness statement, readiness to operate statement, which sets out the kind of the areas by which we will, as a whole system across North East London, have to meet a set of standards really around being able to be assured that we are ready to operate as an ICS, and that's due to sort of be completed around the in line with the April 2022 timetable. So I think that was just a bit of a framework really, so you can understand how things are moving forwards. But I guess I thought it'd be useful to just flag a couple of things that have come out around guidance, in particular around place-based partnerships, and just to give a sense of how we see ourselves sitting in that context, and probably to confirm some of our, what's a strong position for us really in terms of going forwards. So there's a lot of guidance has recently come out last week around a number of components, but the place-based partnership guidance in particular I think's worth a read, and I'm happy to circulate that to people if they're interested. But there's quite a sort of permissive message really amongst a lot of the guidance about it's really for local systems and ICSs and local systems to design how they want to work together, and a strong message that place-based partnerships are the foundations of integrated care, and that they're about a collaboration and an arrangement of all the interested parties in delivering health and care on the ground. The governance arrangements and the activities should sort of flow from that consensus and that collaboration, which I think that's a helpful context for us to continue to operate in. And there's kind of no sort of single approach defining how we need to structure ourselves in a sense, and that's a useful mandate, I think, for us to continue to develop how we work together. There's a really strong piece around culture and behaviours, and moving away from kind of competitive and rivalrous or transactional relationships, and to much more developed relationships across the whole system, and how we work with partners and how we work with provider collaboratives. But in essence, I guess the strong message about place-based partnerships is that they're about health and care, strategic planning, service planning together, including joint commissioning opportunities if that's what we would desire as a local system, how we monitor quality together, how we look at outcomes together, how we plan for our workforce together. And the kind of the skills base that we have as a partnership in terms of service transformation and delivery, and particularly supporting PCNs and neighbourhoods to deliver in that integration at the place-based level. And the other kind of key things, I think, particularly speaking to our sort of health and wellbeing partners around population health management and how we are really getting traction on health inequalities and prevention. All those things are very much mandated as the role of place-based partnerships, and that we still have a really strong role. And I think this speaks to some of the agenda later today around listening and working with our communities and actually delivering population health and services that are actually addressing the things that people want to hear, want to have and need in their lives. And the place-based partnership will have a really strong role in connecting with communities and understanding what it is we're here to do. So I just thought that was helpful to remember that we're in a good place, but we can go further and we can really develop what we do next. Thank you.
Thank you. Yeah, John has asked for the guidance, and I think a number of us would like to see it. So perhaps you could just give it to Alex, and he can send it out to.
Yeah, I think somebody's put it in the chat actually, if I saw. But
yeah,
okay. So somebody circulated the link.
Ah, right. Then that's probably sufficient.
Thank you,
Chris.
Thank you very much, Siobhan. That's very clear, very helpful. Yes, I think many of us have been involved in meetings at various levels. The one thing that came out of the leaders and cabinet members meeting that I just wanted to stress was that although we are tasked with looking at governance, we're all very clear that actually what you talked about really getting traction on some of those priorities, especially the health inequalities and the COVID recovery, actually is the focus. And so we're trying not to put governance first, but to try and work out what the system together needs to do to really get, as you said, traction on health inequalities, COVID recovery, etc., and then work out how the governance best helps that to happen. So it's about making sure we get the outcomes for our population and the positive health outcomes first, and make the government governance a servant, as it were, of that. And the second thing I wanted to talk about was how across the area it's been easy for us in a way being in City and Hackney, because we've had this very good positive relationship. We had basically a City and Hackney wide contiguous CCG that has only recently gone up to the NEL level, and our colleagues in our other North East London boroughs had 3 boroughs squashed into 1 CCG, each of them. And actually, as the ICS and the work has gone on, I just wanted for us to note that when we talk about place and place-based, it is now accepted in the rest of North East London that that is very much at a borough area. So, for example, in Tower Hamlets, they're looking at their local place-based partnership board as being based around Tower Hamlets Together, which is their system of the local authority working with their primary care networks. I just wanted to point that out so that we know we're not for a while we were talking about 3 places within NEL, and it's very definitely 7 places within NEL now. Thank you.
Henry?
Thanks, Randall. Apologies, I was slightly late, so I've only just joined. But I caught the kind of middle part of Siobhan's presentation and then Chris's point. So really, I just wanted to kind of reiterate Chris's points and just kind of back up exactly what Chris is saying. That I think, particularly in terms of the kind of work that we've been doing on a kind of early view of the governance, and frankly, this is not about trying to design the governance and then work back from that. In fact, quite the opposite. And Chris has described it really well, that we should be working through what is our purpose and how can we make a bigger difference with the new ways of working, and then we then fit the governance to support that. The reason that it's important that we take a step back and do that in a kind of a considered way. So I mean, you would always want to do that anyway, but it's particularly important that we do that now because the change in legislation does give us a very profoundly different way of operating together. And the integrated care system, the legislation to create the integrated care board, primarily is about, as Siobhan says, it's about taking away the kind of competition and that commercial aspect of intra-NHS kind of trading. And it's effectively dismantling the internal market that's been in place for 30 years. So we have all in the NHS become quite used to that way of working, and it's kind of second nature. And we consider our colleagues in within our provider services to be colleagues and people we collaborate with. But at the same time, there is this underlying contracting mechanism that does often get in the way of that. And what the integrated care system is really fundamentally designed to do is to bring all partners together as equal peers with equal kind of skin in the game to collectively and collaboratively design a better way of doing things. So that's the reason why it's important that we allow that to kind of settle and to develop in a way that is effective, and then we design the governance at the end once we've got to that point. So really it was it's just really important to reiterate the point that Chris is making.
Yeah, and I would just note that the real action from our standpoint has to continue to be at city and Hackney level, because the governance around NEL is constrained by the legislation. We, in all honesty, aren't going to have a whole lot of representation there because there aren't many seats available for representation. So our focus is going to be on doing the best we can with the hopefully significant portion of the budget that is somewhat within control of the city and Hackney structure. Let's see, I guess next was Helen.
Thank you, Randall. Thank you very much for the paper and presentation, Siobhan. It is helpful. And I was looking at the groups and the ICS strategy group, because what we seem to have talked about more this morning is about the governance and how the governance will follow other things. But what I think we've heard less about is perhaps this is in this strategy group, about what the ambitions or the objectives are for service transformation and design, and what might, in time, might we see the residents of City and Hackney see that's different as a consequence of this, as opposed to talking about it in the generality. Now, it might be too early to say too much about that, but if governance follows, then that has to come pretty early in this stage. And I'd be really keen to hear more about your thoughts or what that might look like and what might be seen to be different.
You want me to answer that now, Randall?
Sure. Yeah.
So I think that's a fair challenge, Helen. But I do think I guess a lot of what we want to do collectively as a partnership has been set out before in the context of the long-term plan and some of the work that we had done. I know it seems like a long time ago with the pandemic, it's like life never existed beforehand, quite honestly, but it is a lot of the work has been, we do need to come back and revisit some of those issues, but and really I suppose picking up the issue around inequalities, how we need to really refocus and hone in on those concerns from a population health perspective. But and I guess the other strength that we might have is that we're all pulling in the same direction, going forwards, which will be different. And I know people sort of maybe don't maybe understand the points that Henry was making about the cultural change is really significant, actually. I mean, we kind of glibly sort of think about it, but it's a major change for all of us in terms of how we operate as collectively. And if we're all in pursuit of the same objectives, that is going to have I'm sure it's going to have an impact. But you're quite right. I think we do need to do a bit more revisiting and refreshing some of that, both locally and across North East London. But I guess we're quite clear that we know what our priorities are on some level, as Chris set out, recovering from the pandemic, all the issues that have been brought to the real forefront around the way that our population, the issues that our population have. But I think you're right. We do probably need to follow that up in a bit more depth in terms of this space and sharing some of those sort of strategic and service transformation objectives going forwards. And I'm happy to make sure that we bring that back.
Good. Mark.
I suppose my point was I don't want to get too esoteric about it, but actually the idea that clearly what Siobhan, you just said is absolutely fundamental to all the work. I mean, it has to inform everything we do. But actually, we do know a lot of what we want to do, and we just need to revisit it, as you said. And I think we also know already that there are key challenges for the governance structure, which is getting the place-based partnerships, functioning. We need to make sure that the challenge between their relationships and, say, the acute collaboratives and other parts of the health system, for example, are right. What goes on at the ICS is right, and the relationship with the health and wellbeing boards and the partnership at the ICS. So we know these things in a way, rather than I see the governance happening afterwards. It's a parallel process. I mean, clearly what you've talked about is paramount, because I would see, if I was to describe our ICS to somebody from another country, I'd say, here are the 7 places. This is our ICS. This is, and by the way, we've got this over here and we've got this going on over there. But it's principally in that way. And I think just trying to we can hold those things simultaneously, although the function is slightly ahead, and we have to keep it. But we have to, and there's a lot of work going on developing the governance. So whether it's for us making sure that the accountability framework is clear from ICS, and this, what's delegated and what's reserved and how the money flows, and we've got our area subcommittee, the equivalence of all of that into the ICS. And across now, there's been a lot of work there. It's just a matter of making sure it continues to be progressed. And I think the idea that some of that will have progressed, and we'll be in a position well before March to start looking at working in a kind of shadow form is really important, I think, in terms of getting that momentum going. So we don't spend all our time defining the what's the point of what are we trying to do, the function, but we can do the form simultaneously in a way. And I think we are.
Good. John,
We've just had the financial settlement for the next 18 months, actually 3 years, but let's say numbers have been put out there for 3 years, but for the second half of this year and next year, pretty firmly set out. And according to our sort of national leaders, this isn't nearly as much as the health service and social care need to both catch up on the backlogs of care and so on in the health service, and to deal with our other pressures. And I think a lot of the decisions about what's going to change, going back to Helen's point, which I completely agree with, is going to be driven and shaped by where the money goes. And what seems to me the biggest change taking place in this legislation is that we're moving to a much more centralized allocation type of system. So in the Homerton, if we did more of this operation or that operation under payments by results, we got paid for it. And we're moving more, it seems to me, to a block budget type system where allocating decisions will be made, first of all, at the ICS level, but also at our level. And I suppose two thoughts come out of that. The first is Henry, I guess, is in a good position to answer this. What's the timetable, if you like, for decisions at your level? So we've got a national pot. No doubt you'll be getting a letter shortly saying that you've got to produce a budget for next year. What's that sort of timetable? And when can we contribute to that about what we want to do in Hackney and City? And secondly, I suppose just a reflection on the role, particularly of the neighbourhood board, the executive element of this board. I think in the past, the ICB has mainly been concerned about how to distribute extra pots of funding that have been delegated to it. So it's a question of where to put extra money. But as I see it in future, it's also going to have a role in what happens to the existing, the base funding, if you like.
Yeah.
And there are going to be some really difficult issues there. So it's quite easy to say, well, for this extra pot we want of 2 million, we should put it into access for minorities of different sorts. Much harder in a way to say, well, how much should be going into acute care and how much should be going into expanding PCN staffing and so on. And as I see it, we're not a sort of body that can sort of discuss that and reach conclusions. We're going to look to the neighbourhood board to come up with a plan. But I think we should be thinking, certainly for next financial year, what changes in the shape of spending should we be looking, should we want to achieve next year, and how real would that be? I think that would be extremely difficult, and I'm delegating it to a different body. I see this body as getting a report on that and making sure that we're comfortable with the direction, but not getting into the detail. But I think, that's going to be work for the next 6 months, really, because by next year we'll be in the new world and we'll have those choices to make.
Absolutely. I think, John, the issue, as it sort of always is in local authorities, is the members, if you will, sort of figure out what the priorities should be, and the officers figure out how to deliver and persuade you that they're delivering in the best way towards the priorities that you've set. So this is, in a sense, something that that at least those of us on the local authority side are sort of used to doing. But it will be very definitely a new world, and in the ICB. Yeah, Helen.
Yeah, thank you. I wanted just to follow up what John was just saying, I think, because what concerns me in a way is that I know that City and Hackney are clear about wanting to tackle health inequalities and very focused on neighbourhoods and place-based. However, the old tensions remain, and the impact of COVID is enormous on the waiting times for people and lots of care that should, in the normal course of events, would have been provided, but of course has been pushed back. And I guess what I'm still not really clear about is how we manage, and you may say that it's not for this board to be directly involved in, but how will those old tensions be managed and resolved, and how do we keep the focus on health inequalities and the neighbourhoods and the views and plans from neighbourhoods coming forward, so that they aren't just pushed away for several years because we need to deal with the impact of COVID. And I know it's a kind of a bit of an impossible conundrum, but nevertheless, City and Hackney needs to find a pathway through that, and find the right balance for City and Hackney. And if that means, and I regret that it's probably necessary to say this, but if that means that some of those that have been waiting, that are, if you kind of call them non-urgent or less urgent than other things, because we need to keep looking longer term and tackle health inequalities, then we need to be absolutely clear about that and the rationale for that, and make it so explicit that people can understand why some of these very difficult decisions are being made and must be made, because we know whatever new money there is, it will not be enough to do everything that we think should happen with a degree of urgency. And
that may make us all somewhat less than popular, but you're right. Yes.
Indeed. Yeah, I'm sure it will. Yeah.
Yeah. Laura.
Thank you, Chair. I would just like to take this conversation a little bit further, because this seems to me to be the heart of our new Integrated Partnership Board, in the sense of we have to, as key leaders and key clinicians, we have to set some principles around this. Yes, other fora will start to work through some of the detail, but we have to make those high-level principles about how much do we want to, what's the relative difference in investment that we want to see in different areas, and why are we saying we want to do it like that? We have to start looking across the entirety of the budget, not just small pots of growth, and we have to start saying this is less important than that for this reason, and engaging the public in that debate, and get to the point where we can give the system some clarity about those those principles and those relative priorities. This seems to me to be the function of this new group that we're on today. And the sooner we start that debate, the better, in my view. It's going to take us a long time. I'm not clear when and how we're going to start that, and it would be helpful to think that through a bit more, I think, because otherwise we risk being a passive recipient of work elsewhere, but we haven't set the framework for that work, and the work then for them may be not the right work and not what we expect when it gets here.
Yes, Honor has somewhat beat me to the punch, but the next item is the co-production charter, and that's that's clearly an area that will be contributing substantially to addressing that issue. Henry.
Thanks, Randall. I'll try and be quick because actually much of what's been said is the points I was going to make, particularly Laura's point about how we can have a better and more effective way of effectively making those difficult choices, but making them in the right way, making them on the basis of what we have already determined are our priorities, and being able to control that better. John asked several questions. Implicit in his question, I think, was that he didn't necessarily expect to get answers to all of them, and that is, that we are working through that. I haven't yet had a formal letter with from the centre setting out our share of the additional money, but he makes a very powerful point, and Helen as well, and Laura, that however much we get, firstly, it won't be enough, and secondly, it will be a struggle to conversely, this sounds slightly odd to say it, but it will be a struggle to spend it all, because we don't have the workforce. It's not just a case of throwing money at the problem. We will never be able to clear the enormous burden of the pandemic simply by creating more cash, because we don't have the workforce to deal with it. So it's essential that we do both of those things, that we prioritise in a way that is safe and fair, most importantly, but also that we do everything we can to find better and more innovative ways of reducing the continuing burden, and that means finding different ways of enabling primary care and others to intervene to reduce the burden of that backlog. And we've been brilliant at doing it in City and Hackney. It's not always been the case across North East London or across London, in fact, that that having that ability to be able to mitigate some of those pressures through a different means of patients being able to access care. I guess just on the point about the financial framework going forward. So John's point about payment by results, it's a good one. Population health should be all about being able to have a deep and rich understanding of the population's need, and then to be able to prioritise our care based on that need, and then to allocate resources accordingly as well. And the plain truth of it is that payment by results was created 20 years ago or more ago in order to drive competition, and it's not an effective tool for targeting resources based on need. There isn't a national solution to this at this point in time, other than an expectation that we will be able to make more informed and kind of locally determined investment decisions, and all of our partners will work together to do that in a way that contracting never really enabled that kind of collaborative, joined up decision making to happen. But I recognise all of the challenges that we have, and to some extent, the solution to those is in working together.
Indeed. I think we're slightly over time, so we probably better move on to the next item, which is the co-production charter. Sally?
Thank you. You all have received the most recent version of the co-production charter in your papers. I'm not going to share screen, I'll just take you through this. So this is a review of the co-production charter that was created in 2017. It's really important to note that the 2017 charter still stands, and that good piece of work that happened there shows that all of the partner organisations agreed that it was important to have a set of principles around co-production universally, and they all signed up to those. And this is work building on that to ensure that it's current and it's living, and it's part of how we work rather than just a dry set of principles. The 2021 charter was produced in a thoroughly co-produced way. We engaged with system partners across the partnership, volunteers and members of the public. We conducted surveys, empathy interviews, various workshops. It's gone through various groups to really make sure we're hearing as many voices as possible to contribute to this piece of work. One of the things that came most strongly out of that work was the need for the charter to be a living practical tool that's part of how we work and not just almost a list of rules. To address this, in the new version of the Charter, we linked to a guide, a how-to guide, pretty much a step by step. If you're new to co-production, this is what you need to do to make it work, and that guide was co-produced in itself. It links to guidance around accessibility. So if you're working with members of the public, making sure that if you're having meetings or events face-to-face or online, that it's accessible to everyone. And that's a really comprehensive, helpful guide, which again was co-produced. A big part of the new version is a series of self-assessment tools, and these will allow the organisations to evaluate their own performance around co-production, and it's a structure that they can report against, so that if they want to report back to people in place, which we'll touch on in a minute, there's something that can be done universally in that way. The Charter also includes offers of support around co-production, partly in the form of looking to develop co-production champions, which would be our most experienced volunteers across the system asked to step into that role and receiving training and come out and then support across the system, and looking at staff, so people like myself and my colleague that works with neighbourhoods, neighbourhood public involvement, understanding that those members of staff are there to help across the system, and we can be accessed and we can be working with people to build on their co-production needs. The principles of the Charter remain broadly the same as the 2017 Charter. There's some additions to bring it a little bit more up to date, so notably offering training on induction and assessing staff against co-production at appraisals where appropriate, so it becomes part of how staff across the system work. And more steps around helping organisations capture a varied voice. Something that's been coming up is that often we get the same public voice over and again in different meetings. So making sure that we're getting a fresh voice in. So that's all included in there. This version of the Charter that you've all seen was taken to People and Place meeting earlier this week. So the function of the People and Place, one of the things that it's there for is to ensure for you guys that a piece of work has been fully co-produced, that the public have been involved, and all of that work has happened in a satisfactory way. I'm happy to say that People in Place agreed that was the case. So I won't bore you with the long details of how it was that we did the various surveys and interviews, but this was a co-produced piece of work which People in Place are very happy with. So we're here today to ask for your endorsement of the principle of the Charter and principles. If you endorse this in principle, we'll take it out to the partner organisations and we will be asking them to sign up. We'll also be going in more detail to the System Operational Command Group to ask them to have a look at the practicalities and allow them the opportunity to discuss it if there's any tweaks, any changes that do need to happen to make sure this will really work when it goes live. It's just really important to know we're not asking the Integrated Care Partnership Board to compel people to sign up to this. We're not about policing the way people work. It's about asking you to endorse it because we hope that if you're behind this, it will encourage the organisations to really buy into this and start working with us to really have a universal approach to co-production and to understand that there's lots of support out there. We're not there to say you're doing things wrong. It's about how can we all work together to do this as well as we can and support each other across the systems and share resources where possible. Individual partners will be given the opportunity to comment before we'll get the final copy designed so it all looks beautifully polished. We hope that we can reach a consensus quite well with the organisations. If we do find that there's any difficulty in really reaching consensus across all the organisations, we may need to come back to ICPB to ask for your guidance around that. And just finally to say that we're keen to ask the organisations to start using this, matching it up with projects and I guess trialling it out as soon as possible because we'd like to start seeing this being used universally. And I think I'll leave it there and open up to discussion.
Thank you. Yes, I think this is a lot of really good work, and we know that in some instances we've done, we have really good co-production and others not so much, and trying to get everybody on the footing of the good will be quite helpful. Honor.
Thank you. I think it's a lovely piece of work. I would thoroughly endorse it. I am particularly interested, though, in children and young people's voices, and I'd like to see a very specific piece of work done, because I think they sometimes get tangled up and are diametrically opposed to parents' voices. And I'm not suggesting that we should listen and take the child's view necessarily every time, but there's such a lot that our children and young people have to say about the services we have traditionally. These are, I'm thinking about the services that are for children and families. They are of long standing, and it's about time we open them up to a thought that they could be better. I suppose I was particularly thinking about how we have designed services for looking after the health of children looked after by local authorities, for example. I think, as an adult with a view, that I would find that those services quite humiliating. And not responsive, and so I long to hear about how we're going to encourage children, young people, particularly children who are multiply disadvantaged, to have a sense that they can co-design things with us. Thank you.
That's an interesting point, Hannah. There's a different strand of work specifically around children and young people, which is the system influences, which I'm hoping may have heard of, which we may be bringing fairly soon to another of these meetings, which really it's a specific way of allowing the young people to be involved and to co-produce work, which is slightly different to the way we've traditionally worked with young people. They're mentored through the system to get involved in that work, and it's been a very successful pilot that we've seen working very well. We've got lots more young people coming on board as public representatives. We're starting to really get more traction with that group of young people, so hopefully we'll see further developments around that.
And I'm sorry, can I just have a second bite at this? I think that's wonderful, but I think young people need to be referenced and talked about inside the general co-production work.
Okay, fantastic, thank you.
Thank you.
Stephanie.
Thank you, and fully agree with Honna's previous comments. Clearly a huge amount of work has gone into this, and are fully supportive of the principles. I guess I'm probably helpful to say I'm representing Tracy as part of the system perspective today, and I think one of the things that came to mind was actually thinking about, you talked about this coming here first and then going to organisation. So I suppose there's something around actually involving the organisations in the production of this, because that potentially before coming here, because I think we just want to make sure that organisations are all bought into it, and also we wouldn't want organisations to be signing up for something that they couldn't achieve for good reason, recognising that different organisations have different challenges and barriers. So I think that was probably my comment and reflection around how to getting that the buy-in and the involvement and engagement from the organisations as part of that initial setup prior to it coming here.
I think that's helpful, and Siobhan, that reflects comments that you made at People in Place. The work was very widely co-produced, so representatives from the organisations were involved in the workshops, interviews and surveys, so there was that element there. What I agree, what I'm hearing from you is missing is that buy-in from I guess the decision makers of those organisations to say yes, 100%, this is practical, this can be rolled out. So that would be the next step. We're confident that this has been designed in a way that it's not a definitive set of rules. If you look, there's parts about a scale of co-production which accepts that not everyone's going to be able to buy in and use it in the same way, co-produce in the same way, but we support people to move up the scale, if that makes sense. So we're optimistic, but yes, I take that on board, that we need to do that work, and
it may be something you want to think about in terms of when you get to producing the final polished document. You may want to think about how each of the organisations and partners are represented as part of that, because actually it's a collaborative approach. Obviously being led and championed through Health Watch, but that may be something that you want to consider as you get to that kind of final polished document.
Yeah, that's helpful. Thank you.
Yeah, I had rather assumed that was, if you will, the next stage. That if we agree this is good in principle, you're going to go out to all the partner organizations that would be expected or hope to adopt it to make sure that they're happy before it comes back in final form for us to recommend their adoption. Is that?
Absolutely, 100%. And what we'd aim for, obviously, is the final polished document, I guess, showing all the logos of all the different organisations to demonstrate that yes, this is something that's bought into across the board. So yes, that is our next step, and I guess I'm anticipating that being potentially quite an in-depth piece of work, going to all the different organisations and coming out with consensus. But I'm optimistic that will work.
But it also needs to be hopefully in place in the very near future so that it can have real input into all this prioritization stuff that we're going to have to be looking at. So,
yeah.
John.
Thanks, Randall.
Williams, sorry.
Yeah, that's right. Thank you. Well, thanks to Sally and everybody who's been involved in to date in terms of in this review, and we do take on board the need to make sure that providers are fully on board of it. As Sally said, there has been some involvement, but we need to make sure that it's full involvement, and we'll be doing that in the next few months. I just got to think. One of the things about co-production is that it's really very good way of actually building confidence in the local systems, because you involve people from the beginning, and you also explain to them about the challenges and also the opportunities that services can do as well. So referring back to the conversation we were having earlier about kind of the challenges that we face around prioritisation, co-production will, I think, be a very good way to actually really work with the public and help the public understand what the challenges are and help us prioritise. I think one of the things I'm really pleased about this particular process is the kind of the backup documents that practically kind of help people work through how to do co-production, because I do think that it can produce anxiety in people, and this is what we really want to work through as Sally talks to the organisations about how they want to work with co-production, because I think it's really important that we have a kind of a unified approach that is kind of segmented but actually kind of really makes sure that we're all working in the same direction. Thanks.
Thank you. Mark?
Thanks, thanks, Randall. Yeah, and thank you. Really welcome the work. A couple of one practical thing was, I think it's on page 40 of the main pack, where it talks about having a good sort of flow of representation of the public, and people having a sort of tenure for a year, and then moving on. I just wonder whether we should just maybe review after a year, because you may not get anyone come forward and actually, the real practicalities of the thing, but also you may have somebody who's developed lots of skills over that year and is really getting going with an ability to and confidence to kind of make an input. And it would be a shame to sort of just say, well, you can carry on, but wait 6 months till there's a vacancy over here. And actually just don't make it quite so mandated. Say it may be a review rather than, that you have to move on. Another thing was there's the self-assessment tool. I was just wondering a bit more about who you anticipated would undertake filling it in, because obviously some people who haven't been involved will clearly say, I haven't been involved. And then, well, of course they weren't involved. But others who were involved will have more or less, just so how you see that working, I guess. And I suppose the last thing is it's very reassuring to hear that you are asking for the ICPB's endorsement, because on the papers it said approval, and we're not in a position to approve it. And I just kind of make sure that we, that's good. I'm glad to hear that.
Okay, it's good. I'm glad that I've clarified that a little bit more. First point, yes, I agree. There needs to be some flexibility around the tenure of public that are involved, but there needs to be a mechanism where people are comfortable with moving on to other opportunities, rather, because it often seems that there's people for many years in one place. Their knowledge is amazing, and in a way it's difficult to move people to the next opportunity, because you want to hang on to that knowledge, but in a way, because of all that knowledge, they're just another professional in the room, so it's keeping that voice fresh. But I agree.
Maybe a year, it feels a little short. Time really moves quickly, doesn't it? But actually there needs to be a point where they say that is it, 2 years worry. And as Sandra's put in the chat, actually there are many other factors that play into that decision. It just felt a year, that's it, felt a bit sort of.
No, that's a very good point. I take that on board. Thank you. We'll have a look at that.
Who undertakes the self-assessment?
So the way I envisage this is that would be a very much a co-produced part of the process, that everyone that's going to be involved around the table in that co-produced work would have the opportunity to sit together and discuss, because it's not a long set of tools, those are self-assessment tools. So I would hope to see all of the members of the public, volunteers, everyone that is going to be involved, setting aside some time at the beginning of a project to work through that, and then once every 6 months, for instance, to review and go through those, so everyone is in the same place. What I don't see is if one person takes on the responsibility to just go and fill that in, then you immediately lose that co-produced element. So I would hope that that's how that would be happening, if that makes sense.
Yeah.
Okay.
Okay.
I guess it would be guidance to how it's then implemented, so people kind of understand that expectation. Yeah.
Okay, we can clarify that. Thank you. That's helpful.
We're running a smidge over time, so I'm gonna. I've got 3 people with hands up, but I'll take those. But I think they'll have to be the end of it. So, Paul first.
Thank you. So first of all, just to really welcome this paper, and I suppose for me, my question was just how we are going to be able to keep an eye on how we are progressing on the journey towards co-production, because obviously we've got the ladder of co-production in there, the different types of ways of working, and I guess I think it will be really important for us to sort of see and learn together how we really build up to everything that's in the real co-production element, about leading together and designing together and delivering together.
Yeah, that's helpful. I mean, for me, the role of people in place as almost holding this document and where organisations come back to report to, it's a two-way street. So as the people report back to people in place would be offering support or guidance, or here we go, would we like to link you up with a co-production champion to help people move towards that? And I'll be looking to see a series of reports over the course of time around the charter coming from the tools, and which people in place can then give us a wider picture of what co-production across the system is looking like by putting those reports together potentially.
Chris?
Thank you. Thoroughly welcome this. Good piece of work, Sally, and happy to endorse. The one point I wanted to make was that co-production, it doesn't quite come through enough for me, is something that you have to do all the time. You must always be co-producing. There are certain projects that I know we've done from a council side where we reach out to residents, ask them to become involved at the beginning of, say, a 2 or 3 year project. You get a few residents very closely involved. You end up holding it quite tightly to them. When you go out with a finally delivered scheme 2.5 years later, loads of people put their hands up and go, why wasn't I asked? You've got to keep asking and keep co-producing, and I'd like to see that come through a little bit more. Thank you.
Thank you.
Yeah, and I think that's sort of the tension in the refresh that there was some challenge on. So yeah, the balance between really hearing everybody and Siobhan, and then I will also let Anne ask her question, but I'm really not going to take any more hands on this topic, or we won't get to the next topic. Siobhan, yes.
Thanks, Randall. I won't be long. I just wanted to say, really, Sally, yeah, in terms of the feedback about going through some of the other parts of the system, I'm very happy to support you with that. And I think, we all as partners, I think, need to support this as a way of working. And some of the points that Mark has raised around implementation, and maybe we need to think a little bit about how we support that as a collective endeavour as well. So we need to put some people into this way of working. So just to give you that message that we're here to help.
Thank you. That's really helpful. Thank you.
And Caroline Miller had put in the chat that what resources are available to help people with this, and hopefully that'll be answered in the new version as well. Obviously, they're the mentors and things. Anne.
Thanks. Just quickly to congratulate Sally on a really thorough piece of work, and the way that it's being co-produced is really impressive. So I think it would be useful to have some sort of review, as someone else has mentioned, about how this is all going. And I think that is a piece of work that could be overseen by the People and Place group. It's also really helpful. I think we've had no trouble previously in signing up to principles, but having the toolkit and the practical support is really going to help us now start to apply the work. And I think it is worth recognising there's already a lot of good co-production work happening. We're just not necessarily aware of it. So again, part of the role of People and Place will be to share and review that information and celebrate it and share good practice.
Great, thank you.
Thank you.
Okay, so we're going to move on to agenda item 7, and I think, Jonathan, you're going to be introducing this.
Thanks, Randall. I was actually going to pass over to Ava, who has written a report and done most of the work in this area, and I can pick up any questions that are directed at me or where Ava wants me to provide any additional context. So I'll hand over to Ava. Thank you.
Oh, okay. Oh, and just for the minutes, I really ought to have formally gone through, but City and Hackney, City is happy to recommend this to go on to the next phase of co-production, and I assume Hackney is as well.
So it's Hackney.
Yes, excellent. Right. Okay, so over to you, Ava.
Thanks very much, and thank you, Sally, again for that great piece of work. So for those of you who don't know me, I'm Ava Horviel, and I lead on public engagement in City and Hackney as part of the North East London CCG. And I'm here today to present a paper on the People and Place group, where we've got to with that. But importantly, also hopefully have a bit of a discussion with you all about how this board would like to work and interact with that group. With the People and Place group going forward. So just as a reminder of anyone who's new on the call today, the People and Place group is a subcommittee of this board, and it has a remit around ensuring that patient and public involvement, co-production, equality and diversity, and social value and sustainability are considered throughout the partnership. And it's not a new group, so we've been working for quite a while to get that up and running. We do have a review terms of reference, which is attached in your papers today. And we've also developed a set of value statements, which is a really a good document to have a look at as well. It's also attached in your papers. So the terms of reference obviously describes the work that we do as a group and what we're there to do. And then the value statements came about at the development sessions that we had earlier on this summer, when it became evident that we also want to kind of articulate how we do our business. So there are statements there around committing to accessible language, committing to promoting equity, active listening, things like that. And so, as I say, we had a couple of development sessions with system partners earlier this summer, and we're now about to have our third official meeting in October. And just to give you a flavour of the sorts of things that we've got on the agenda coming up, we are expecting an item from the quality team. So Jenny Singleton and colleagues are currently working on quality assurance framework, and they are looking at lots of existing patient feedback, but also talking to a number of different special interest groups and patient groups about what their thoughts are about what's important about quality. And then we look forward to having that discussion with them in October, where the People and Place group can then look at how these things, so how have patients been involved in that, how has social value, equality and diversity been considered in agreeing those priorities. We also look forward to having an item from East London Foundation Trust, just on the consultation and engagement and the work that is happening around the move of or the Columbia ward, the Casaubon ward, which is now situated in my end, and that change kind of potentially becoming a bit more long-term arrangement. So we'll be having that in October. And also the group has taken a really keen interest on digital exclusion, which has obviously been highlighted during the pandemic. So they are really keen to understand how that work is taken forward across the partnership and what's happening around that. And really just the final thing to say, I suppose, is that in order for the People and Place group to do their work effectively and to assure themselves and assure this board that these things are being considered, it needs to be informed by a really wide range of community insight. And we're just in the process of kind of formalising those arrangements. So how can we make sure that we get regular flow of community insight from diverse sources? So how do we bring together all the various engagement groups and patient groups and resident involvement groups and channel that feedback into the People and Place group so that they are then in a position to inform themselves and also inform this board about what are the topics that matter to local residents. So we're working together with Healthwatch and other local partners on that. I'm going to hand over to you now, and hopefully you will have some thoughts and questions as well on really how you would like us to work with you going forward. What would be helpful? How can we share information with you? How often? In what format? And anything else that you might want us to take on board as we move forward with this work. Thanks very much.
Right. So thoughts? No one has any thoughts? Chris.
Yeah, I really welcome hearing you say a wide range of community insight and how you consistently have a wide range. I think our the one danger of, for example, detailed surveys about the result, what people feel about a particular service, is that you tend to get the people who had a particularly bad experience, or the people who had a particularly amazing experience will go into great detail because it's something that absolutely resonated, echoed, and was a huge and vast part of their life. And while sometimes those detailed testimonies, especially when they're talking about where there's been a failure, absolutely must be heard and absolutely do need to lead sometimes to change of practice. Understanding how a system and a part of the system is doing is only really done if you get a large volume of consistent data about outcomes and what people feel, and I think just making sure that we have consistent mechanism of capturing that wide range, I think is absolutely key. It probably for further down the line from this board about what particular type of information we might want on a regular basis, what sort of data we'll be asking is something I think we're still working towards, but consistent methods of capturing a wide range, absolutely key to this. Thank you.
And Stephanie?
Thanks, Ava. It's really good to see this paper, and it's clearly a crucial part of the work that we're going to be doing in the short and longer term. A couple of comments from me was, I think it's really important to have theory. It's really important to have a set of principles that everyone can work to. You can build momentum with that. But I suppose what I'm more interested in is how then you convert those principles into practice, into reality. You know, and we've worked together quite closely on the vaccination work, and actually it's that implementation and that reality and that work in practice that then really builds the change. So I think I would welcome more focus, or more to come back on the practice and the reality and how you make that work kind of across the system. And really, as part of that, how do we support our practitioners, our clinical leaders to be able to implement those changes? So I think for me it's how do we convert the principles into reality and support our people on the ground to do that.
Thank you. That's helpful. I can come back on some of those thoughts, or,
yes,
or
please.
there are other comments from people.
That's all the hands I have at the moment. So yes,
right.
please.
So yeah, really good points. Thank you both. We absolutely, first of all, Councillor Kennedy's point about ensuring that we've got a wide range of feedback. Yeah, that is absolutely what we want to kind of strive towards. And we're working with Healthwatch and others on kind of formalising that process a bit better. So we obviously we do gather a huge range of both quantitative and qualitative feedback through a range of methods, but what we are beginning to do now is as well as kind of offer people the opportunity to come and have their voices heard, to then analyse and code that information a bit better, so that it's easier for partners to make use of that. So at the beginning of a project or service redesign, they've got something to refer to in terms of what people are already saying about that. And a key tool that we are hoping to use for that we're beginning to use, is the Community Insight database that Healthwatch hosts, and they have an agreement across North East London for that. So that's a database of community insight that can generate reports on particular topics in terms of what's good, what's not working so well, what people are saying about particular services. So yeah, absolutely. And we hope to have a regular report come to the People and Place group from that Community Insight database, probably quarterly, so that we can be kind of informed. And then Steph's point on kind of making the values and the principles reality, and actually kind of acting in a way that are in line with those principles, it's good that you're flagging that. That was also flagged by Sonia Khan at our previous People and Place group session. So that's something that we're looking at in terms of making sure that they're not just something that's on paper, but that they become kind of real, and that there's support in place for clinicians and practitioners to do that. And just worth noting, I suppose, that for now those value statements are just something that the People and Place group themselves wanted to kind of articulate for their own work, but there's absolutely potential, and we'd be really keen to explore expanding that to system partners and seeing if those value statements were something that others wanted to implement too. Thank you.
And Anne?
Yes, thanks. I just wanted to, follow up on Stephanie's point as well about the sort of putting things into practice. And we see part of the role of the Community Involvement Forum as being a sort of a place for people to come to discuss issues in detail. So if clinicians, for example, have a particular set of questions that they would really value getting input from the public, they can request that, and we can set up sessions at the Community Involvement Forum. So that's very much what that is for. It's meant to be a sort of feeder group for the People and Place group on some of those detailed questions. So we want it to be seen as a really good practical opportunity for people to raise issues and get some public feedback on. And then on the value statement, yeah, we're quite keen on really testing this out, and we're going to review ourselves against it as the People and Place group in a couple of months' time, just to test ourselves to see whether we actually have been meeting these values, and getting feedback from our partners and our members on that, as well as a wider range of other performance measures that we're going to put in place for the group.
Right. So just to finish off on this, I wonder if anyone has any views on how often we should hear from the People and Places group about they're going to have this quarterly insights dashboard and other things, and how often do we want to see that? Honor? Honor?
Busy waving and unmuted. I do apologise. I don't have a view about this particularly, although I'd like to see it often because I think it's very interesting. But it just reminds me about having a schedule about seeing things from all those groups. So the Neighbourhood Health and Care Board, when are we expecting to see that work coming regularly? I wonder if we should just think about a sort of a cycle for this meeting.
Yeah. Siobhan?
I was just going to, yeah, I mean, Honor's quite right, really, in the context of a forward plan. And I think it also speaks to the point that Helen made earlier around, you know, the kind of strategy. And, you know, we just haven't kind of quite got rolling with that rhythm yet, but that is very much on the cards. And I can see that quarterly probably does seem, I would agree with Chris's suggestion in the chat that quarterly feels about right for this, but there's a number of other things we need to factor in, I guess. And also reporting back. I know Tracy's going to be reporting back through a executive's report for going forwards as well. So some of those other things may get covered through that process, but we just need to start to embed some of these relationships between the different parts of our system as a forward plan going forwards. Forward plan going forwards, but yeah.
Yes. Caroline.
Yeah, I was thinking about the agendas, and I'm new to this. I'm a new member, so I'm coming to something that's kind of pre-existed, but now it's something, or turning into something different. I think we need to think about the agendas in terms of, you know, there's some of the stuff that is process, there's some of the stuff which is we're being reported to, we're being informed about things that are happening. There's some of the stuff that we've got to interrogate and challenge, and I would like to see the agendas set out in that sort of ways. You know, what's for information. What is the really important strategic stuff where we're discussing why we're here, what we're trying to achieve, you know, and I think I think those are big questions about how we operate all together. But I think by structuring the agenda in that kind of way, and some of the stuff that Siobhan's talking about too, I think it might help us to focus on what's really important here and not get bogged down in things which are perhaps less important.
Yeah, and I think we're, you know, it's probably going to be helpful to develop some sort of statistical dashboard that we get with regularity, but we don't necessarily need a paper behind it. And, you know, yes, we'll be working that out over the next few months. Okay, I think we need to move on to the next agenda item, which is emotional health and well-being strategy. And Amy Wilkinson is going to introduce this.
Thanks. Hi. So this brings back to the board the final draft of our 0 to 25 integrated emotional health and wellbeing strategy, following some recommendations in July. And just to kind of re-establish it, sets out our drive toward integration. It refocuses our resource and our thinking around prevention and resilience, and it provides a framework for a really complicated and complex system of delivery around emotion and mental health, and sets out how that sort of works together. And I'm sure you'll agree that's really really key right at the moment, thinking about a system that is under quite a lot of pressure and that future-proofs the next 5 years in terms of the way that we want to work. So we have taken on board comments in 3 particular areas that came out of the board last time, and really helpfully spent some time with Honor, redrafted a section on page 69 in your pack, which is around articulating our aspirations, looking at quality of parental relationships, and that's really closely linked to resilience work. Made sure that the prevention focus is articulate all throughout the document and the action plan, and finally made sure that the emphasis on schools is really clear, particularly around the parity between physical and mental and emotional health. So those are the 3 key changes that we've made, and it's really here for your final sign-off and approval.
So we had fairly robust pushback on some elements last time, and I think we've this is a good new effort. Honor, what are you happy now?
Is it not the purpose of this committee to make me happy? I would just like to thank Amy and colleagues for the huge amount of work they've done. It may not look like much to you, but there really was a very significant piece of work. And I know that my preoccupation is just one of many, but I was so grateful that it felt it had a place, it fitted well. And it just means, I think, interestingly, that City and Hackney must be perhaps the only system that has articulated this in this way. So I'm hugely grateful. I thought it was excellent when I first saw it, and I think it's even better now, and they're to be absolutely congratulated. Yeah,
I mean, our job is not to just rubber stamp these things, it's to seriously engage with them, and I think we did a good job of that, and you especially, Honor. So, so if no one else has any comments on this, can we now approve it for publication? So let me ask the city if it's happy to approve. Yes. And Hackney?
Yep. Yes, thank you, Amy.
Terrific. Yes, thanks very much.
You're welcome. Thank you.
Okay, we now have Sunil to tell us about money.
Thank you, Chair. I think Ian Williams is on the call as well. So what I'll do is I'll give a brief City and Hackney update, and I'll ensure that next time round we receive a full report of the financial position. So the update I'm going to give for City and Hackney is for month 4, last month, against a 6-month budget that was set for City and Hackney ICP, totaling around £265 million. So the message back to colleagues around the table is that as at month 4, City and Hackney ICP declared a break-even position. In the main, all of the portfolio of spend across all the programs was break-even. There was a small cost pressure within the acute area of spend, specifically relating to the independent sector, but that's being managed and mitigated with the use of other reserves that are available to us. And it was expected, and it's within our risk appetite. So in the main, the City and Hackney ICP is breaking even. The 6-month forecast is to break even, but that said, there are ongoing cost pressures that we need to be mindful of, specifically around prescribing, continuing healthcare, and some other areas within the corporate spend area. But those will be managed and mitigated in coming months. With regards to the North East London CCG, again, working to a 6-month budget on allocation totaling just under £2 billion. The NEL CCG is predicting or forecasting a break-even position, but the NEL CCG position is a combination of the ICPs and centrally held spend. And again, there are some cost pressures relating to acute, prescribing, CHC, and other areas within primary care, not delegated, that are being managed and mitigated through other measures and other reserves that are available. I'll pause there to take questions for City and Hackney, and specifically around NEL as well.
So, any questions? Chris?
Any detail yet for us at a NEL level about the, I'm thinking particularly of the announcement about the 478 million for the continued hospital discharge team support that was announced yesterday? Thanks.
Nothing has come my way in terms of the extra funding, but once I'm cited on it, I will share that with colleagues. There is an ongoing review of that situation within the NEL CCG and the ICP, so nothing as yet. And just to add to your point, we're still waiting on guidance relating to the wider second half planning cycle from October onwards. So that's still outstanding. Colleagues will remember that at a previous update, I mentioned that we've set our budgets this year for 6 months, and then we redo the exercise for the second half of the year. So we're still waiting for that guidance as well.
Okay, any other questions? No, well, thank you. So we'll move on to the risk management update. And this is, I think, a somewhat more expansive update than we've had recently. We've sort of not paid perhaps as much attention as we ought to the risk matters. Rachel.
Thank you very much. So yes, this is a new process and a new reporting way of reporting for risk management. So I have met with all of the leads and risk owners, and this has primarily been with CCG staff, though there has been some local authority and OMITM input as well. But what we're trying to do is start developing a system-wide risk register. So I've actually asked all leads to take their risk registers to system meetings. So actually we can begin to develop it, begin to input from different areas, so that it is actually about risks across the system and not just from a kind of CCG point of view. So we have only brought the red risks, so the high level risks, to this meeting. Lower level risks are kind of being managed at workstream levels. Though as an ICPB, you can ask for any risks to be brought to the meeting if you would like to. But the risks here, I guess, are the ones that might inform discussions that you're having and feed into other areas. So the process which I've outlined in the pack is that each month the risks will be reviewed and reported here. And also from next month, we'll also include a report that just shows if there's been any movement in risks, particularly those that have kind of increased their risk level. How we will work it is that actually if you have any questions on specific risks, if we can't answer them for those who are present on the meeting, then we will go back and ask all of those leads to feed that into the updates, and also then we can put that into the report. So we are reporting 11 red risks currently. Most of these are relating to recovery from the pandemic, but as you'll see, there are mitigations and updates for all of them. I don't know if you would like more information or if you've got any queries.
Yes, I was very happy to see this because we started trying to put together system risk, I think, as much as 3 years ago, and it's good to see that we're finally making some real progress on this. Chris.
Just to say, welcome the new approach. Thank you. I'll be quite honest. The old massive work stream risks, all I ever did was look at the red ones, and I think for many of us, that's all we ever used to do. So to have them prioritised, brought forward for us, and a narrative around them absolutely makes sense. Thank you.
Good. Thank you.
Anyone else? Does anyone have any questions around any of the specific risk? John. Eve.
It's not so much on the specific risks as a question about what's in scope and what's out of scope. A lot of these are sort of operational risks right at the moment, pressures on the budgets or whatever. There are some longer term risks to health and social care in Hackney coming from changes in financing allocations, for example. I mean, we might learn about that. We're on a long march, really, away from, if you like, the Labour government allocation, which was pretty favourable to inner city areas, towards a Conservative allocation, which is more favourable to rural areas. I expect that to continue. So, there are those sorts of risks. And then there's a huge risk, as Henry was saying, around shortages of staff in terms of meeting our longer term goals. So just a question of how you put your apples and pears together here. In other words, how do you balance longer term strategic risks against the short term immediate sort of issues you're having to deal with?
And could I just add a bit to that, which is, it seems to me that those risks that John is talking about are the ones that might well not fall out of the process naturally, because you sort of build it up from each of the individual work streams problems. And so I think that's probably the most important thing, is to ensure that the sorts of things that John is talking about are included.
And I'd absolutely agree. I think it's really important that we have both operational and strategic risks on the risk registers. I guess this is the start of the process, and actually it's really helpful to get feedback on risks that you as a board would like to see included. I think as we begin to share this across the system in system groups, that will kind of encompass more operational and strategic risks. But I think if there are risks that you would like to see on here, then we can very happily add them. And if it's helpful, we can split it between an operational and strategic risk.
Good. Siobhan. Oh no, Siobhan is frozen again. I don't know if you can hear and go out and come back in again, or right. Yeah, I think, does anyone else have anything on this? No, then I think we'll move on. And Siobhan, are you unfrozen now?
I don't know. I have no idea.
We can hear you. Yes.
I just wanted to concur really with some of the feedback, in that I think Rachel's really been helpful in articulating how we're very much at an early stage, because we're not an organisation as a partnership, and how do we develop a kind of assurance and risk framework around us as a partnership is quite a journey that we need to go on, in terms of some of the specifics that John has highlighted, and where that might be actually sitting on other organisational risk registers in the system, but how we actually create one that belongs to us all. You know, there's a bit of work to be done there, really, and that's certainly what Rachel is kicking off that process, basically.
Yeah. Good. So more on this shortly. I think we'll, unless anyone else has anything else they want to say on that, we'll move on to AOB, of which I think we don't actually have any, and reflections. Anyone have any reflections? No. Well, Chris.
Just a very quick one. A lot of what we've talked about, especially in the chat, has been about how we do stuff here, what we want to see, and I think we just need to remind ourselves, and it's absolutely right that we should be, we're very much in a state of sort of flux at the moment as a partnership board, and sort of establishing who we are, what we do in terms of, you know, the bigger ICS system, and making sure that we're not just a talking shop, we're not just repeating stuff that happens in other meetings, and that you know, especially that talk we had about the budget decision, those difficult decisions, setting the priorities for our area and taking those hard decisions. We have to make sure that is actually what we're doing, and just to keep that at the forefront of our mind for the next few months as we shape ourselves for the future. Thanks.
And let's see, Honor.
I thought it was a really interesting meeting. I think we've covered a huge variety of topics in rather different ways. I'm also intrigued that Chris challenged us to think about governance as a mere function, which is of course what it is. And I think today we've been doing some of that. We've been thinking about how we want to do the work we do, and then the structures that will support it. And I think that's interesting, because that's the things about who we are. But it just reminded me very powerfully, and I said it earlier, that I really have no sense at all about how the neighbourhood health and care board is going, and I feel that given that our governance structure, but more than that, our work actually depends on it being that engine, that motor. So I really would like to see some sort of quite detailed. I was very struck, I suppose, by the People and Places report. I would like to see something similar to give me some assurance for next time. Thank you.
Yeah, Siobhan has put in the chat, and I think she's probably right, that perhaps we need a development session to discuss some of these things. And we should look into scheduling that in the next couple of months, because we really do have, well, the ICPB is actually taking on quite a bit more responsibility in the ICB, and you know, we're going to have to develop a lot clearer structures for priority setting and budgeting and things like that. We just need to figure out how we think that should be done. Caroline Miller.
Apologies, yes, unmuted, sorry. Yeah, just after I put my hand up, Siobhan suggested a development session, and I would absolutely agree. I think we do need something like that. I think this meeting has shown us, I think what's been good about this meeting is that we started to do things. By doing things, we are beginning to learn how we can do things better. So I think that will happen, and we've got time to do that. It will evolve over time, but I think it's been really helpful to have some of these conversations about how we do things, what we're here for. And I think in a development session would where we really, you know, would it be possible to do that in real life? I don't know, but for, you know, to really sit down and focus on that would be fantastic.
I think it may very well be possible to do it in real life, where we in the city have returned to in-person meetings substantially, and I think Hackney has as well. So I think we probably could do it in real life. Julia.
Thank you. Just a quick reflection. I'm brand new in the system. I started last week at the Homerton as the new Director of Strategy, and I'm here today for the Homerton, although of course John is here as well. Just to say, having been involved in this type of work in other parts of the country, most recently in the Northwest, I just wanted to say I'm so impressed by the quality of this meeting, the maturity of the conversation, the fact that there's so many voices that are being heard and inputted, and also the quality of the papers. I think is brilliant. I just wanted to say that.
Great. Well, thank you and welcome. So anyone else? No. We will actually have finished early. John, your hand is up, but I think it's a legacy hand. Is that correct, or did you want to add something?
Well, I suppose I did want to add one thing.
Yeah.
I mean, I think City and Hackney are in a very good position to be to set the standard for place-based integrated working in London, because we've got a tradition of close working. You happen to have a hospital which is largely devoted to City and Hackney, which is an independent unit, and so on. So it puts us in quite a privileged position. And I think looking at it from that angle, we need to get on with things. So if we get on and say, well, these are the sorts of changes we want to make, this is how we want to use our money, that will be influential across NEL and more widely, because other boroughs particularly, are still sort of at the early stages of sort of transitioning from sub-regional to borough-based partnerships and so on. So I think, coming to Chris's point, so we should be trying to get into the having an influence on next year's budget, for example. And that, for us, you know, we've got plans to make, staff to employ, and so on and so forth. We need to get on with that as soon as we can. Now, I know that, you know, I feel this is rather a perilous thing for us to be talking about, because on the one hand, we've got the mammoth BARTs at the ICS level, which threatens to gobble up all the funds. And in this meeting, I can see Laura and others thinking, well, we've got to move some money out of the acute sector into the community sector. So I'm trying not to feel defensive about it, but I think we've got to get into that discussion. That's my main point. I thought it was we've sort of reached agreement that we will do it, but we've now got to actually do it.
Absolutely. And as you pointed out, you know, the movement from payment by results is all by itself a very, very substantial transition, and layering everything else on top of it is, yeah, we've got some challenges. Well, thank you all very much, and see you, is it October 14, if not before. Bye.
Bye all.